In this video, I have managed to put together certain topics that you should know before taking your Step 2 CK exams. You may decide to do this video, like to watch this video before doing your uworld or your shelf, or you can also do this video after it, and this is just for a quick review. And if you know the topics already, you still can listen to it as a podcast. If you don't know it, I'm going to also explain some of them as much as I can, but I'll be really fast. So let's begin. So the first things that we are going to talk about is PSC and PBC. So what I will do going forward is some of the topics I'll put them side by side so that in the questions they'll put them together and you should be able to differentiate them. And then usually we are left with two options and we end up picking the wrong one. So I'll try to give you some pointers that will help to be able to differentiate. So primary sclerosing cholangitis versus primary biliary cholangitis. So both of them are cholangitis, inflammation of the bile duct system. And so both of them are inflammation of the bile duct system, cholangitis. And primary sclerosing cholangitis is a progressive idiopathic inflammation and fibrosis, that's a key word, and stricture formation of the intra and extrahepatic bile duct system, versus the biliary cholangitis. It's an autoimmune condition and it affects the intrahepatic bile duct system only. PSC usually occurs in men. Usually they have ulcerative colitis, that's the association. So if you see C here in UC and also C in sclerosis, so you should choose your answer. If you see a male with history of ulcerative colitis, it's most likely going to primary sclerosing cholangitis, versus the primary biliary cholangitis is in women. A B for women, B for bitches. So just remember, it's autoimmune, and usually the patient will present with another autoimmune condition, say type 1 diabetes or a thyroid problem. All the symptoms are almost the same, except the primary biliary cholangitis may have vitamin D, E, K deficiency. Diagnosis, we do ERCP or MRCP to visualize the biliary system. Primary sclerosing is also associated with P-ANCA, whilst primary biliary has anti-mitochondria antibodies. In primary biliary cholangitis, we will have increased alk phos, increased bilirubin, increased cholesterol. We do liver biopsy for primary biliary cholangitis for diagnosis. And on the biopsy for primary sclerosing cholangitis, you will see anion skinning or periductal sclerosis. Again, you've seen the word sclerosis. They may use another synonym for sclerosis, so pay attention to that. Treatment for primary sclerosing is stenting. We place a stent into the common bile duct, and we can also do ursodeoxycholic acid, liver transplant when the disease is advanced. For primary biliary also, we can do ursodeoxycholic acid. It slows the progression of the disease, liver transplant as well. We can also do cholestyramine if there is itching. Let's move on to the next thing. Damping syndrome versus short bowel syndrome. In damping syndrome, the stomach is damping food too quickly into the duodenum or intestine. Example, if the patient goes for partial gastrectomy, we've cut away part of the stomach, so the size of the stomach is so small that if the patient eats, it just goes quickly into the duodenum, and it can present with signs of hyperglycemia, vasomotor symptoms. So vasomotor symptoms like flushing, tachycardia, hypotension, palpitation. They can also have signs of babarygmus, the noise that we hear in our belly when we are hungry or we are too full. They can also have bloating, diarrhea, cramping, excessive hunger, because the stomach is where we feel hunger. So when it's empty, quickly we'll feel more hungry. They can also have nausea and vomiting. Let's look at short bowel syndrome. It's due to post-intestinal resection or gastric or bypass or intestinal bypass surgery. So if you bypass any segment of the GI tract, what is going to happen is that the effective length of the GI tract is going to be short. So this person is going to, the exit time or the transit time from the mouth to the anus is going to be short. And these people, they may have signs of electrolyte. They may have electrolyte and fluid imbalance. They may have malabsorption. They may have weight loss. And also their symptoms depend on a part of the GI tract affected, or which was bypassed in the surgery, or which was resected away. So if it involves the terminal ileum, we know vitamin B12, folate, and fat-soluble vitamins are absorbed in the terminal ileum, so they'll have the deficiency of those vitamins. Also, if the duodenum is involved, we'll have deficiency of all the divalent cations, the cations that have 2+, so iron 2+, magnesium 2+, calcium 2+, aluminum 2+, zinc 2+. They may also have deficiency of vitamin C. Vitamin C also if the duodenum is affected. And we know the signs of vitamin C deficiency, scurvy, and so on and so forth. All right, let's look at the next things that critically can confuse us. We have hepatocellular carcinoma and cholangiocarcinoma. So in hepatocellular carcinoma, this patient is going to present with tenderness in the right upper quadrant or pain over there due to liver enlargement, and they are going to have progressive weight loss, jaundice, and coagulopathies, since certain clotting factors are being made in the liver. So if the liver has a cancer in there, they may have coagulopathies. Usually, it occurs in chronic alcoholics, patients who have cirrhosis. They progress later into hepatocellular carcinoma, and aflatoxin in farmers, usually who deal in hay, and then there is this, and then grains, those who store grains for a long time. There are aflatoxins that are released, they inhale it, and they can get hepatocellular carcinoma. Patients with chronic Hep B and Hep C can have hepatocellular carcinoma. Let's look at the diagnosis. So for a cancer in the liver, we can do CT. CT scan is the gold standard because it's going to help us to be able to know if there is any met, or if the cancer is a localized cancer or it is a met from somewhere else. Ultrasound can also help us know the shape and then the edges of the liver, if it's smooth or not. And we can also do LFTs, and we'll have abnormal LFTs. We'll also have increased alpha fetoprotein, very, very important. You will always see this in it. Now, these ones are going to be less, or they will be normal. So CEA 19 and -9 and CA 19-9 and CEA are going to be normal, but ALK4s can be high if there is a bone met. So don't get confused. If you see increased alpha fetoprotein and also increased ALK4s, it's because the patient has hepatocellular carcinoma that has met to the bone. So bone met, it's representative of the ALK4s, alkaline phosphatase. Treatment, we can do partial hepatectomy depending on the part of or the amount of lesions that we have. So this is some criteria here. If we have one lesion that is less than 5 centimeters in size, we can do partial hepatectomy. And also if you have 3 lesions that are less than 3 cm, we can also do that. Liver transplant if there is a cirrhosis. So if the patient had cirrhosis before developing hepatocellular carcinoma, we have to do liver transplant for them. Let's look at cholangiocarcinoma. So cholangiocarcinoma is a bile duct adenocarcinoma, and it affects intra and extrahepatic bile duct. Symptoms are similar to a patient who may have hepatocellular carcinoma, but these people usually have dark urine because there may be a stricture formation or obstruction of the biliary system, and conjugated bilirubin leaks into the blood and it colors the urine. We also they have common bile duct involvement. That's how come there's biliary stasis. And risk factors are primary sclerosing cholangitis, ulcerative colitis. They can also, people who have some certain parasites like the liver fluke can also cause this cholangiocarcinoma. So let's look at the labs. So diagnosis is made by increase in ALK force. Definitely ALK force is always increased when the biliary tree is involved. GGT may be increased, CEA 19.9 or CEA may be increased, CEA 19.9. There is normal alpha fetoprotein, so that tells you that the liver is not involved. Let's look at the next differentiation. Jaundice. So jaundice, some people love to think about it whether it's obstructive or non-obstructive. Then we can also look at it if it is conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia. So if it is an obstructive jaundice, always the stool is gonna be pale. Remember that, and they'll have dark urine. This dark urine, they'll have dark urine because it's conjugated. So they'll have dark urine. Non-obstructive jaundice, there is yellowing of the sclera just as in the obstructive, but you have to determine if it is conjugated, like we have a Rota and Dubin-Johnson. They are conjugated, so they'll always have dark urine. If it's unconjugated, it could be due to hemolysis. Let's look at other. Before then, let's look at the biliary tree, and then we'll look at how to differentiate the various types of jaundice in the next slide. So this is a biliary tree, and then we have small bile ducts here, and then they all unite. So this is half of the liver, the left side of the liver, and this is the right lobe of the liver. And so coming from here is the right hepatic duct, and this will be our left hepatic duct. They unite to form the common hepatic duct. So right and left unite to form common hepatic duct. The next thing is we have the cystic duct, which is the duct that is draining the gallbladder. So there's a cystic duct will join the common hepatic duct over here to form the common bile duct. This is a common bile duct, CBD. And now, as the CBD comes down, we have the main pancreatic duct, the duct of Wesson, main pancreatic duct, which is the duct of Wesson, will join the common bile duct to form the ampulla here. They join at the ampulla of Vada here. And now the common bile duct will open into the duodenum at the sphincter of Oddi. So there can be obstructions all over here, or like on the way. There can be obstructions up here, there can be obstructions up here. So they'll all present with different symptoms. If there's obstruction here, they'll present with different symptoms. Imagine if a patient has a cancer at the head of the pancreas, it's going to obstruct here. So they'll have signs of possible pancreatitis. They may also, and then they'll have signs of stasis in the biliary system. So that's obstructive jaundice. So this is a more elaborate diagram. The liver has been taken away, so we can see over here. Later on, we'll refer to this video. So this is the duodenum, this is the gallbladder here, and this is our pancreas. The main pancreatic duct is here, the duct of Wesson. The accessory pancreatic duct is here, the duct of Santorini. We can see the ampulla of Vada, and we can see the sphincter of Oddi here, ampulla of Vada here. Okay. Now let's look at other causes of jaundice. So we are going to classify jaundice per this slide. We'll classify jaundice into prehepatic causes, the intrahepatic causes, and the post-hepatic causes. Prehepatic causes are things that happen in the blood. So for example, if a patient has G6PD and they're taking a drug like TMP-SMX, they are going to have hemolysis. And then if they also have spherocytosis, they are going to have hemolysis, in that the breakdown RBCs are going to be too much for the liver to cope with. So these are some of the causes. Let's look at intrahepatic. Intrahepatic, we can have two types. It could be due to non-obstructive biliary disease or mechanical biliary obstruction. So if it is due to mechanical obstruction, if there's obstruction in the liver, inside the liver, so it's still intrahepatic obstruction. Like a liver tumor can cause that. We can also have intrahepatic gallstones. We can have congestive hepatomegaly or hepatopathy, in that if a patient has right-sided heart failure, they can have engorgement of the liver because the blood will pile back into the IVC and the liver becomes enlarged. So that will cause congestion hepatomegaly. And we can also have primary sclerosing cholangitis, which will also cause intrahepatic stasis. And in this case, the patient is going to have signs of either mixed, or they may also have signs of conjugated hyperbilirubinemia. Let's look at the non-obstructive. Non-obstructive means that there is no obstruction. So these are diseases that usually affect the hepatocytes themselves and not the collecting duct system. So we have hepatitis, liver cirrhosis, again congestive hepatopathy, and we have primary biliary cirrhosis. Also, cystic fibrosis can also be a cause. And the last one is the post-hepatic. So post-hepatic also, in post-hepatic is going to be due to obstruction of the common bile duct mostly. So here we have disease like choledocholithiasis, and we can also have inflammation of the common bile duct system, and we can have malformation, some tumors like the pancreatic tumor. If there's a tumor at the head of the pancreas, it can cause obstruction, as I said earlier on. And we also have the bile duct strictures, can also cause obstruction. You can pause the video and look at this chart very well. So jaundice is grouped into two branches here. We can see indirect and direct hyperbilirubinemia, and direct is also known as the conjugated, indirect is unconjugated. So let's look at the indirect first. Indirect, as we said, is mostly pre-hepatic. So we look at things like hemolysis, we look at hemorrhage, internal hemorrhage, we look at things like here we have impaired hepatic uptake of bilirubin, so some drugs can cause that, and also things like portosystemic shunt. We have defective conjugation of bilirubin. So defective this time is the enzyme glucuronidase transferase is not available. So in children who have Crigler-Najjar, they have total absence of the glucuronidase transferase. In Gilbert, they have a little amount, but it's not sufficient. So they go without jaundice, but when they engage in strenuous activities or they have some surgery or some activity or dehydration, that is when their symptoms come up. And we also have neonatal jaundice as a cause of unconjugated hyperbilirubinemia. Let's look at direct conjugated. So direct, we can divide it into three parts. What we have to do is, if we do liver enzymes and the liver enzymes are all normal, then we know that the most likely cause is going to be Dubin-Johnson or Roto syndrome, whereby the liver has finished conjugating, but it is not able to transport it into the biliary system. Another thing we can look at is if AST and ALT are high, meaning that there is a hepatocyte injury, so hepatocellular injury. Now let's look. If AST is greater than ALT, in the ratio of 2:1, most likely it's going to be alcoholic liver cirrhosis. Let me stress this again, very important. If you see AST and ALT, always check to see if the ratio is 2:1 or higher than 2:1. That means that it is going to be alcoholic liver cirrhosis. I can explain this in a little bit, in that AST is mainly in the mitochondria, but ALT is only in the cytoplasm. AST is in the mitochondria and the cytoplasm. So when you have alcoholic liver cirrhosis, the alcohol is able to destroy both the mitochondrial membrane to release more AST and also destroy the hepatocyte outer cell membrane. So it also release your ALT out. So 2 sources of ALT makes the ratio 2:1. So take note of that. Now, if ALT is greater than AST, then it means that your mitochondria is intact, so you have less AST. So diseases like hepatitis A, B, C, drugs, autoimmune hepatitis, and primary biliary cholangitis can cause that. Now let's come to this part of the chart. Now, if you do your liver enzymes and then you realize that it does not fall into any of these, your AST and ALT doesn't fall into any of them, then you are looking at ALK-phos and GGT. If ALK-phos and GGT are high, you are looking at a cholestasis, because ALK-phos and GGT mainly are in the biliary duct system. So you want to think of cholestasis. Now we have to do ultrasound imaging to see if there is a dilatation of the bile duct or not. If there is a dilatation, then it's most likely biliary obstruction. So we have things like cholelithiasis, that's a stone. It can be a tumor from the head of the pancreas, or also primary sclerosing cholangitis causing strictures inside the bile duct. If you do the ultrasound and there is no dilatation, then it's most likely an intrahepatic cholestasis. So that could be a liver disease, primary biliary cholangitis, it could be sepsis, or a postoperative cholestasis, or also pregnancy. So this is something that you can take time and then study very well. Next thing is gallstone ileus. This is very important. That's why I added it to it. Very important. Everyone should know this. So anytime there is an inflammation of the gallbladder, that inflammation can irritate the large bowels. When it irritates the large bowels, it can cause a fistula. Over here, it's going to cause a fistula. And so if there is a fistula, if there is any stone in the gallbladder, it's going to fall into the into the large bowel, or into the small bowel first, and then it will travel to the large bowel. Again, if there is inflammation of the gallbladder, that inflammation can irritate that inflammation can irritate the small bowel and cause a fistula. If a fistula forms, if there's any stone in the gallbladder, it's going to fall into the small intestine and travel to the cecum area. Now, when it gets to the cecum area, because there is an ileocecal valve, the stone cannot go into the large bowel, so it gets stuck in the ileocecal valve, and this will cause signs of small intestinal obstruction. I hope that's clear. Now, if they do surgery, this is the stone over here, and then they can remove it. So this will be lodged at the ileocecal valve. If it goes into the large bowel, we will pass it in the stool, so that wouldn't be a problem. But mostly the stones are so big that they get lodged, and we'll need surgery to get them out. So this is it. So if you get a gallstone ileus, you are always looking at a triad of pneumobilia. Over here you can see air in the bile duct. You also see a radiolucent stone or a mass over here in the right lower quadrant, because the ileocecal valve is at the right lower quadrant, and this patient is going to present with signs of appendicitis. They will feel some pain inside, but when you do all the Rovsin sign and co, they wouldn't be positive. So they'll have left lower abdominal pain. they may not necessarily show you an image like this for you to see, but they'll tell you the patient has air in the bowel duct and then have left lower abdominal pain and then signs of intestinal obstruction. And let's see this image. What are the signs of small intestinal obstruction? You can see that this is the small intestine here, and then you see these lines here. These are the placi secularis, and then they run through the entire width of the small intestine. So that tells you that it is the small intestine. If it's a large intestine, you wouldn't have the lines going through. So this is it. Let's go to the next. The next thing is mesenteric ischemia. So mesenteric ischemia, simply, it's just like a heart attack that is happening in the intestines, or in the bowels. Let's put it that way. So we are going to look at two main things. A patient who has developed a new holosystolic murmur and having severe abdominal pain. So in this patient, they are having bacterial endocarditis, and that has caused a new mitral valve prolapse. So if you look at this image, there are bacteria here on the mitral valve, and these bacteria can easily dislodge and go into your aorta and then go into the systemic circulation and blocks the vessels. For example, the SMA they are going to block the SMA, and the SMA supplies blood mostly to the mid-gut. So there'll be a mid-gut ischemia, which can progress into necrosis, and that will they'll start showing signs of bloating and signs of peritonitis if there is perforation. So let's take note of that. A patient who has a new holosystolic murmur and complaining of severe abdominal pain, we should think of this phenomenon. Let's look at other causes. So other causes are atherosclerotic occlusion of the SMA, and we can have vasospasms of the SMA. We can have thrombosis in hypercoagulable states. Shock is another thing that we should look at. A patient who presents with shock, and after they get better, they are complaining of abdominal pain. It may be this, and the area is most likely the watershed area. And so let's take note of that. That is the splenic flexure. And also the rectosigmoid junction is another place that they can have this problem. It can also be due to a blunt abdominal trauma. So with that, the patient comes to you with a blunt abdominal trauma. You see them in the ER, they go home, and 2 to 3 days time they come with severe abdominal pain, or they come with abdominal distension, and most likely the trauma caused is thrombosis and occlusion of the SMA, but did not present at the time they came to the hospital. Yeah, let me talk about this concept here. So some patients may have severe weight loss, and that can lead to intestinal obstruction. In that, if you see here, this is the aorta, this is the abdominal aorta, and here is our SMA. And when you look at it in this picture, you will see that the duodenum is passing under or in between the SMA and the abdominal aorta. So there is a fat pad that is cushioning the duodenum so that the SMA does not press on it. If someone loses weight rapidly, what is going to happen is that the fat pad is going to disappear, and the duodenum will be compressed by the SMA, and that can also lead to small intestinal obstruction. Let's take note of that. Let's move on to the next thing. Or before, the intestinal mesenteric ischemia can be diagnosed on a CT scan, and will have pneumatosis intestinally, and also CT angio, whereby we can see the clots in the vessels. So when the patient can management to be IV fluid, antibiotics to prevent progress of the inflammation or infection, and also we can do anticoagulation, bowel resection if there is evidence of infection. The next thing is blunt abdominal trauma. So why I added this is that sometimes just knowing that the when someone has a blunt abdominal trauma, and if they tell you there's fluid in the retroperitoneal space or intraperitoneal space, then that tells you that, okay, if the bleeding is in intraperitoneal, then these are the organs involved. If it's retroperitoneal, these are the organs involved. So these are the retroperitoneal organs, and they're the sad packer, as we can see here. We can see some of them, the kidneys here, suprarenal gland is here. We can see the pancreas is here. We can see the duodenum is here. We can see the vessels, the great vessels. So we can see the aorta and the IVC are here. The ureters are here. And the rectum is also there, but we don't see it over here. So these are the organs, sad packer. So suprarenal gland, aorta, IVC, duodenum, pancreas, ureters, the colon. So we have the descending and ascending colon. And the rectum is also part. The kidneys are part, and the esophagus. Let's look at the next one, liver injury versus splenic injury. So if someone has a blunt abdominal trauma, this is a presentation here. Like, we want to be able to tell if it's due to a liver injury, if their bleeding is due to a liver injury or is due to a splenic injury. Usually, if it's a liver injury, it's going to be right-sided. And if it's a splenic injury, it's going to be, the trauma is going to be mostly to the left side of the patient. But sometimes they give you the presentation and tell you that they have rib fracture. Bear in mind that the spleen is not in the thorax. So if there's a rib fracture, it's not going to affect the spleen. Now, so a patient with post-trauma presents with distended abdomen and diffuse abdominal pain. And then they did a portable chest x-ray, and it shows multiple rib fractures. On the right side, rib 8 and 9 are fractured. And on the left side, rib 4 is fractured. The patient has no pneumothorax. And then they did a FAST score, and there is no pericardial effusion, but they have a large amount of intraperitoneal free fluid. So already we know that it is not the sad packer. They are not retroperitoneal, it's intraperitoneal. So if we rule out all the retroperitoneal from organs from the answer, then we'll be left with liver and spleen. Now, how do we know that it's liver or spleen? This patient has both side, right and left sided splenic fracture. Right and left sided rib fracture. And we already established that the spleen is not in the thorax, so it's not the spleen. It's most likely going to be the liver. Also, the 8th and 9th ribs are lying just over the liver, so that should make sense. Note that bleeding behind the liver is retroperitoneal. If they tell you somebody is bleeding behind the liver and it's a slow bleeding, most likely it's going to be the IVC, which is retroperitoneal. The way they love to test the splenic injury is that a patient came to you with, they were involved in an accident or trauma, and then they came with, maybe they presented with abdominal bleeding, and so they did a surgery. Which vaccine should we give to the person? We should be thinking that since the spleen houses most of the macrophages and they are able to fight against the encapsulated bacteria, when we remove the spleen, they will be prone to encapsulated bacteria, which are the shin vaccines that we should give them: strep pneumo, H influenza, and Neisseria. Also, they are susceptible to salmonella, because also encapsulated. So usually that's how they would love to test splenic injury with micro. And mind you, the spleen is also intraperitoneal. So if there's a splenic hemorrhage, it's going to be intraperitoneal free fluid. Next is to differentiate between focal nodular hyperplasia and hepatic adenoma. This also is confusing sometimes on the test. So focal nodular, it's a benign, and mind you, both are benign. It's a benign liver nodule, well circumscribed, hypodense mass with central scarring. So when you see central scarring, that is for focal nodular hyperplasia. It's going to be in a woman who is between 20 to 50 years. And this woman will be taking OCP. If they are taking OCP, OCP is not the cause of this. So the patient should continue taking the OCP if there is a central scarring. This cancer does not transform into malignancy. Hepatic adenoma is also a benign liver mass, usually on the right lobe of the liver. It's going to be in a woman who has been taking OCP for a very long time. These people should stop OCP. And this mass has centripetal enhancement on triphasic CT, and there is no central scarring. If there is no central scarring, they should stop taking OCP. Okay. So here, let's try to identify this tumors. So when we look here, we said one of the tumors had central scarring, and this is the focal nodular hyperplasia. And when we look at this CT scan, this is the liver here, this is the liver, and this is the nodule here. And the nodule has a central scar, as we can see. So that tells us that is focal nodular hyperplasia. Let's look at hepatic adenoma. This is the nodule here, and it's on the right lobe of the liver. There is no central scarring. And again, we can see it here on this gross anatomy. Next is small bowel obstruction versus large bowel obstruction. We have to be able to differentiate these two, especially on imaging. So small bowel obstruction, we have symptoms of abdominal discomfort and pain, possibly accompanied by visible peristaltic waves in the upper and in the middle abdomen. It's mostly going to be in the upper abdomen, whilst the large bowel is in the lower abdomen. And so it's going to be upper or mid epigastric abdominal distension. They have nausea and vomiting. The vomiters may contain fecal matter. They have obstipation. They have severe fluid and electrolyte balance and metabolic alkalosis because they are throwing up all the acidic content, so to be left with alkali. Let's look at a large bowel obstruction. They have intermittent lower abdominal cramps, lower abdominal distension. They have minimal vomiting, or there may be no vomiters. They have obstipation and also ribbon-like stool. There is not any major fluid and electrolyte imbalance here, but they may present with metabolic acidosis because the bowels have more alkali. So bicarb, they have more bicarb. So when they lose all the bicarb, they are going to present with metabolic acidosis, but it's not always present. So on imaging, this is how it's going to look like. We already talked about small bowel obstruction in the previous video. So if you see the small bowel here, this is the small bowel here, and then you can see the lines across it. They are running straight through it, and these are the placi secularis that are in the lumen of the small bowel. We can see them all over here. So that tells you that this is a large bowel obstruction, and then this is more in the mid abdomen and upper abdomen. Here is the lower abdomen here, so below this line. Now let's look at the large bowel obstruction here. So this is the bowel here with air in it, and what we can see is the hostrations, and they don't run through the entire width. So it's just here and here. So this tells us this is a large bowel obstruction. Next is Ogilvie syndrome versus paralytic ileus. So ileus is just the inability of the bowel to function as it should, and they are not able to generate the peristalsis that they normally generate. So Ogilvie syndrome is localized to the colon, so it is an ileus of the colon, and it is a pseudo obstruction. Ogilvie syndrome has Bowel sounds that are hyperactive initially, they may be described as high pitch, and later on they become absent. They have mild nausea and vomiting, may pass flatus, may have diarrhea. Etiology usually is post-diarrhea or post-vomitus. And when somebody has been vomiting or having diarrhea for a long time, they have electrolyte imbalance. And this electrolyte imbalance will predispose the person to, or will cause ileus. And they are hypokalemia, hypocalcemia, and hypomagnesemia. Also, some drugs like opioids, so like morphine and Demerol, those can cause Ogilvy syndrome. Also, anticholinergic drugs and antidepressants. So patients usually after surgery, if they are taking these drugs for maybe for pain, or they are resumed on their home meds, they can have Ogilvy syndrome. And we said it was limited to the colon, so they will have this sign, this one here. This one, the colonic obstruction. So that's what was large intestinal obstruction. That's what they will find on when they do abdominal X-ray for them. So treatment is surgery. Other causes. I'm talking about other causes, not the treatment. So other causes are surgery, trauma, infection, and usually we can see it in patients in the ICU also. And management is, first of all, you have to stop the patient from putting anything in their mouth. So NPO, because the bowel is not working, why do you want to add more stuff to it? We can do NG tube decompression, and we can also do rectal decompression. We pass a rectal tube. If it's becoming so severe, we can give them neostigmine and perforation if it's not treated. So this can lead to perforation. Now let's look at paralytic ileus. It can happen on any part of the GI tract. Okay, any part of the GI. So one, we can have absent bowel sounds. They have nausea and vomiting, obstipation. They have the same etiology as the Ogilvy, but these other symptoms may be pancreatitis, decay, and then spinal injury at T5. Treatment is lactulose and a prokinetic and erythromycin. So lactulose can stimulate peristalsis, and also erythromycin can do same. Prevention is by, for example, if a patient comes from surgery, what we do is that we let them chew gum, and when they chew the gum, it's kind of like sham feeding that stimulates their brain and the GI tract to start resuming peristalsis. And management is almost the same. Next is pilonidal disease. Pilonidal disease versus pressure ulcers. So pilonidal disease or pilonidal disease, forgive me if I'm not saying it well, it's infection of hair follicles in the upper gluteal cleft in young males mostly. So if you look at the gluteal cleft, the upper part, that crevice over there, the hair follicles, the men have a lot of hair distribution on their body. So that some of the hair follicles can get infected over there, and it may become pus. So when they palpate the infected part or the skin over there, it's going to show a fluctuant mass. So anytime you see a fluctuant mass at the upper gluteal cleft, it's a pilonidal disease, and it may discharge pus, blood, or mucoid substance. Risk factors are a young male, an obese male, and someone who has a deep gluteal cleft. Surgery to drain the fluid, and they can do open closure. Versus pressure ulcers. We can have pressure ulcers on the coccyx. Pressure ulcers are ulcers that develop when our pressure points, like the elbow, the back of the head, that's the occiput, our sacrum, the back of our foot, are placed on an object or a pressure point for a very long time. So that will cause blanching of the area and reduce blood supply, and over time there is necrosis of the tissue, and that will lead to an ulcer. So that is a pressure ulcer. So these pressure ulcers, especially the one at the coccyx, can mimic the pilonidal disease. We should be able to differentiate them. So in this picture, we can see this is a gluteal cleft here, and then you can see so much hair over here, and this is a cyst. So if we drain it, there's gonna be pus. If we palpate it, it's gonna be fluctuant. And this is when they open it up, they remove the pus, it becomes hollow. So they can do closure of these holes, or they'll do dressing for some time. The next one here is the pressure ulcers. So pressure ulcers, as we described, mostly is on the coccyx and the sacral area, because there's so much pressure there when we lay down, especially in the obese patient and bedridden patient. So we have different stages, we'll go through them. Now, the fact that you see redness on somebody's pressure point does not mean they have pressure ulcer. First thing you have to do, if you're not sure, is to tap on the place to see if it's blanchable or it's not blanchable. So what we can see here, it is turned white. That means that it is blanchable. Blanchable means that the blood vessels are still intact, so when you press on it, the blood just goes back into the blood vessels, so there's no damage to the blood vessels. In a pressure ulcer, there will be damage to the blood vessels. So when you press on it, it is not blanchable. That will be pressure ulcer stage 1. So let's take note. This is it here. This pressure ulcer stage 1, the skin and the epidermis are intact, but the area is not blanchable. Pressure ulcer stage 2, the epidermis is off, has been turned off. Now, pressure ulcer stage 3, you will see that the epidermis and dermis are all gone, and the subcutaneous tissue is what is exposed here, right? Pressure ulcer stage 4, the subcutaneous tissue is gone, and then we can see the underlying tissues like the muscles, right? And and sometimes we can see the bones also. Those are the deep ones. And there's another one called the unstageable, where we'll see slug or some whitish necrotic material all over a deep pressure ulcer, and then we can't tell whether we can see the bone or not. So that is unstageable. Next is radiation proctitis. So we have acute and chronic radiation proctitis. So radiation proctitis is going to be in a patient who has had radiation maybe in the last 2 years or last 3 years. So acute usually is less than 8 months. They have a bleeding and inflammation of the rectal mucosa, and so this is going to be in a patient who has had radiation for, let's say, something like a pelvic tumor, so maybe a colon cancer. They've had a radiation treatment for ovarian cancer or something, or rectal cancer. Then all of a sudden they come with bleeding, and when it's less than 8 months, we know it is acute radiation proctitis. Now, if this is occurring greater than 3 months to, let's say, 2 to 3 years after the radiation treatment, then that is chronic. These people have severe bleeding, rectal pain, and they may have strictures. Now, when we do anoscopy or colonoscopy, what we are going to see is we'll see friable mucosa with multiple telangiectasia and mucosal pallor. So that tells us that it is a chronic proctitis, chronic radiation proctitis. You must always see friable mucosa and multiple telangiectasia. That's what bleeds. So let's take note of that. Next is diverticulitis versus UTI. This might sound weird, but sometimes a patient presenting with diverticulitis might mimic UTI. So let's see how that resemblance, how we can deal with that resemblance. So a patient presenting with diverticulitis is mostly going to be an older patient with left lower quadrant pain, because the sigmoid colon is mostly affected. If it's in a younger patient, it's going to be the ascending colon, because there's a lot of pressure in the ascending colon as well. So older patients, sigmoid colon; younger patients is going to be in the ascending colon. So typical presentation is left lower quadrant abdominal pain. They have urine frequency, urgency, nocturia, and all the urinary signs. due to bladder irritation. They have anorexia, fever. When we do urinalysis, they are going to have elevated WBC due to inflammation of the bladder wall, but no nitrates, no leukocyte esteresis. And complication of diverticulitis is going to be colon vesical perforation. Since the diverticulitis can irritate the bladder, it can also lead to perforation. So what we want to do is that let's avoid colonoscopy in a patient that we suspect diverticulitis. If you suspect UTI also, I'll say avoid colonoscopy, because it may be a diverticulitis that is irritating the bladder, and if you do colonoscopy, you are likely to perforate the colon, and that will increase the person's hospital stay. Urinary tract infection. In this patient, they present with the same urinary symptoms, but WBCs, nitrates, and leukocyte esteresis might be high. One of them or both will be high. So WBC will always be high in both of them, but let's look at the nitrates and leukocyte esteresis to know whether it's definitely UTI or it might just be a diverticulitis. Mind you, the older patients might just present with altered mental status when they have a UTI, because they are not able to they may not be able to report the urinary frequency, urgency, or that might even be their symptom already. That's how they are, their baseline. That's their baseline already. So the next thing that we want to look at, do they have an altered mental status? So if they present that way, the next thing is just do urinalysis to see whether there is elevated WBC, nitrates, and or leukocyte esteresis. So here we go. This a colonoscopy done in the colon, and this a diverticulum is not inflamed. And diverticulum, we said it is a false. This one is a false diverticulum, right? Just due to pressure. So it's just the mucosa and submucosa that are moving through or pushing through the muscularis, versus the Meckel diverticulum that is a true diverticulum. The Meckel is a true diverticulum. Yeah, and so here, this is where we have, this is a sigmoid colon here, and we can see that it has irritated the bladder. This is the urinary bladder. There is irritation, and also there is perforation. So when there is perforation, what you are going to see is that the stool content of the colon is going to go into the bladder, and the patient is going to pee urine that is mixed with stool. Someone might think that it is coming from the vagina, but it is not from the vagina. We need a critical examination to be able to differentiate the two. Next is Biliary versus portal venous thrombosis. I'm adding this because it's very important. So when there is Biliary is a bad guy. So in Biliary, the whole liver is going to be swollen because the thrombosis is occurring in the hepatic vein, in the central vein here. There's thrombosis in the central vein. So any blood that is coming is going to stop and cause enlargement of the liver. This will also lead to edema in the feet. So let's take note of that. Versus portal venous thrombosis. In the portal venous thrombosis, it's occurring at the portal triad level, at the level of the portal triad. So it's happening behind the liver. We've not yet gone into the liver. So the liver is spared over here. But what happens is whatever is coming from all the organs that give venous return through the portal system into the inferior vena cava will have congestion. So as we can see, the vessels on the stomach wall are all congested, and then the splenic vein is also congested. So let's take note of that. If you see edema in the leg and also swollen liver, is the bad guy, the Biliary. Next is atraumatic splenic rupture. So we can see the spleen is ruptured, just ruptured. Atraumatic means that this patient did not sustain any blow. Maybe they were just at a gym working out normal, or they are just engaging in some sports, and all of a sudden they started having hypotension and abdominal pain, abdominal distension, and they will lose consciousness. I mean, this is a massive thing, because the spleen is very, very vascularized, and you can see this whole thing is a ball of blood, blood that is there. So on CT scan, this is what we see. We can see hemorrhage here. You can see blood all over here in the peritoneum, and it's going to be intraperitoneal, so blood all over here. So that tells us that this patient has a splenic rupture. There are many causes of this. So if something like that happens, a patient presents with just hypotension, and then they have this abdominal pain, is something that we have to have high suspicion for, else we may miss it. There are some patients, they'll be at the gym working out and then they fall and then they just die like that. Like, this is some of the things that can cause that. So we have infectious mononucleosis. Usually it's post-infectious mononucleosis. So we advise them not to engage in any active spores after the infection for about 1 or 2 years. And so if the patient, this infection is caused by CMV, EBV, also patient with leukemia, history of leukemia, malaria, cirrhosis. Cirrhosis can cause splenic congestion, splenic congestion. Pregnancy can also cause splenic congestion. Medications like anticoagulants will increase our risk for bleeding. Granulocyte colony stimulating factors can also, like the filgrastim and co. Next is that this patient usually, this is a typical presentation. So they are going to present with left upper quadrant abdominal pain that radiates to the diaphragm, or sorry, it will radiate to the shoulder, but because it's going to radiate to the shoulder because of the diaphragmatic irritation. And so when they bleed into the abdomen, the blood is going to irritate the left side of the diaphragm and to radiate to the left shoulder, and they'll have signs of hypotension, and that should raise a high suspicion for this. Next is post-cholecystectomy syndrome versus the bile acid diarrhea. So in post-cholecystectomy syndrome, these patients, after we do a cholecystectomy for them, they still will have similar or same disturbance or pain in the right upper quadrant as they had before we did the surgery. So that means that there may be something that is still persistent. For example, they may have retained stones in the common bile duct. They may have dysfunction of the sphincter of Oddi due to spasms or due to opioids medication like morphine or Demerol. They may also have some hematoma in the common bile duct. So let's take note of that. If a patient, after we've done cholecystectomy, they should have some relief. But if they present with the same symptoms, then it's most likely post-cholecystectomy syndrome. And what we'll do is we do an ERCP to go and observe inside the common bile duct. Next is the bile acid diarrhea. So let's try to differentiate the two. In bile acid diarrhea, this person may also be one that has done cholecystectomy surgery, and now they are having jaundice and diarrhea. So in this patient, what is happening is that they are having excess bile in the colon. Because now there's no gallbladder to store it. So when it's coming from the liver, it just goes straight into the GI tract. So when they have excess bile in the colon, they are going to absorb more of that bile into their blood, and then they'll have symptoms of jaundice. Next is that they will have diarrhea because the bile acids will cause some irritations in the colon, and that would also cause diarrhea. So the causes are post-cholecystectomy, excess secretion of bile, and malabsorption of bile, and also sphincter of Oddi relaxation. For some reason, sphincter of Oddi cannot close, so the bile will just be coming into the GI tract, and they'll have diarrhea. And treatment here is cholestyramine or cholestipol. These are bile acid sequestrant. They prevent us from absorbing them. Next is pancreatic pseudocyst. So this is a major topic that there's a lot of information I've put here. I'm not comparing it to anything, but I just want to talk about the pancreatic pseudocyst. So pancreatic pseudocyst is a collection of leaked pancreatic fluid, which is a complication of acute or chronic pancreatitis. There are many causes of it. As we see here, it could be due to infection, trauma, hypercalcemia. These are all risk factors. Cystic fibrosis, autoimmunity, and hypercholesterolemia are all risk factors. So whatever the case may be, it's just that there's some leakage of pancreatic fluid, and that has formed a cyst in the pancreas. The diagnosis is by ultrasound guided biopsy, and this biopsy, what we are doing is we want to determine if the cyst is high risk or it's low risk. High risk cyst should be resected. Low risk cyst possibly would have spontaneous resolution, so we do nothing about it. Now, these are some of the features of high risk cysts. So this high risk cysts, they have potential for malignant transformation. That's why we resect it. So one, if the cyst is greater than 3 centimeters, we want to it is a high risk. If it has a solid component, if it is calcified, if the cyst involves the main pancreatic duct or is causing main pancreatic duct dilatation, it's high risk. And also if the walls are thick or irregular, that tells us that there's a potential for malignant transformation, and then we do surgical consult for such patients. Next, here is the imaging for the pancreatic pseudocyst. So as we can see, this is the pancreas here, this is the whole pancreas here, and then this is the cyst on the pancreas, as we can see. And here on this imaging, it is so big. Look at it. It is really big. This will be greater than the 3 centimeters they are talking about, and this will be causing compression of certain things in the abdomen, and then surgical consult should be done. It can also split open and cause hemorrhage. I've seen this splitting in the hospital, and that was my patient, and it split open and the patient passed on because it was severe intra-abdominal bleeding, and then we did everything to resuscitate him, but he couldn't make it. So when we see things like this, let's take note and do surgical consult for them. So here also we can see the pancreatic pseudocysts here, and the whitish things there are all calcification. So this is another high risk feature. The next thing is abdominal compartment syndrome. This is a very important topic also, that you need a very high clinical suspicion in order to diagnose it. So talk about it real quick. So abdominal compartment syndrome is when the intra-abdominal pressure rises and is sustained at greater than 20 millimeters of mercury, and this is causing a new organ dysfunction or an organ failure. So we have different levels or different classifications. So mainly it causes symptoms when it is greater than 20. So usually it presents in patients who are critically ill in the ICU, and or patients who have pancreatitis, they have or Ileus, or patients who have had extensive abdominal surgery or abdominal trauma. And organs mostly affected are the heart, the lungs, and then the kidneys. So what happens is that this high intra-abdominal pressure is being transmitted into the thorax. The pressure is transmitted into the thorax, so it's going to push against the lungs, or we are going to have problems with the lungs. That pressure is going to increase the intrathoracic pressure, so venous return coming is going to be affected. Also relaxation of the left ventricle during diastole is going to be affected as well. Now this same pressure is going to push on all the venous systems in the abdomen, especially the renal vein, so that venous return from the from the kidney is going to be impaired, and that will transmit backwards and then decrease our GFR. So let's take note of this. So let me just go through some of the cardiac sequelae here. So some of the cardiac problems are decreased cardiac output and increased central venous pressure due to both are due to compression of the inferior vena cava. There's also portal venous compression, and also increase in the systemic vascular resistance. So all this will lead to hypotension. So cardiac, we have increased central venous pressure, we have decrease in the venous return due to compression of the IVC, and all this will lead to hypotension. One more thing is there is also pressure on the left ventricle, so it's not going to be able to relax, so that will also decrease our preload further and cause hypotension, and they can even go into shock. So high suspicion, ICU patient, massive abdominal surgery, and they have abdominal bloating and they are going into shock. Let's think of abdominal compartment syndrome. Pulmonary, they will have decrease in the thoracic volume because there is pressure coming from the abdomen against the thorax. So decrease in the thoracic volume, and they have elevated peak pressure from the compression of the diaphragm against the thorax. And so there is also decrease in our ability to expand the lungs, right? And they will have hypercarbia. So let's think of that. They also have decrease in the PF ratio. Renal, they have compression of the renal vein, as we said earlier, and that will decrease our GFR and decrease our urine output. So let's take note of that. Neurologic, this pressure can be transmitted into, as we said, there is elevated central venous pressure, like when there is compression of the inferior vena cava, that can also lead to elevation of the central venous pressure as well. And also there is increase in the intrathoracic pressure. So all the vessels that are draining from the head, the internal jugular, they will all have pressure building on them, and that will increase our central venous pressure. And anytime there is increase in the central venous pressure, it transmits into the brain, right? And that would increase when it transmits into the brain, to increase our ICP. Anytime there is increased ICP, that means that our effective perfusion of the brain is not, cerebral perfusion pressure is going to decrease, and then the person will start having symptoms of altered mental status, and so on and so forth. So that is, if I remember this formula very well, it is cerebral perfusion pressure is equal to cerebral perfusion pressure is equal to the ICP minus the central venous pressure. So that should tell us that cerebral perfusion pressure is going to decrease. So thank you very much for joining me on this video. If you like the content of this video, kindly subscribe so that I can bring you more of this. I'm going to do more of such videos, and then you can use them as a quick review when you are going into your exams. So thank you very much for joining me on this one, and I wish you luck in your studies. It's doable. Let's do it together, and then we will make it at the end. Thank you. See you in the next video. Bye.